So welcome back. I'm Marta Wask. I'm a group leader here at CBMR. And it's my great pleasure to introduce our next speaker, Dr. Leslee Shaw. She's a professor of medicine and cardiology at Icahn School of Medicine at Mount Sinai. Her work has been focused on cardiovascular clinical diagnosis of ischemic heart disease. She has more than 800 publications on this topic. She has been awarded with several awards, including the Bernadine Healy Award in Women's Cardiovascular Disease from the American College of Cardiology in 2020. She's the editor of several impactful journals in the field of cardiology, including the Journal of the American College of Cardiology Cardiovascular Imaging. And she will be talking to us about evolving approaches to diagnose coronary artery disease. So it's a great honor to have you here, Leslee, and please, the floor is yours.
All right. Everybody has their lunch and they're ready to go. I'm a cardiovascular researcher. I'm a clinical researcher. You know what the worst thing to do for a clinical researcher is to speak to an audience of mostly basic scientists. So I'm going to do my best. I hope you'll be gracious with me. But let's have fun. I want to keep you awake for the rest of the afternoon. So here we go. Just some relevant support disclosures, mostly from rich people, which is important. At least it is in the United States. So I don't have to tell this audience. You may not know anything about atherosclerotic cardiovascular disease. Nothing. You know the term, you've heard it, you know it has to do with the heart and the vascular system. That's all you know. But likely, most of you know that it increases diabetes increases the risk, prevalence of atherosclerotic cardiovascular disease at least twofold, and more in higher risk patient populations. So I'm not going to spend a lot of time on this slide. It's all forms of atherosclerotic cardiovascular disease. I'd rather talk to you about some evolving approaches to diagnosing atherosclerosis, which is really exciting. At least it is to me. So the best thing in the world is to find something you're passionate about. So since the late 50s, early 60s, this was our approach to diagnosing coronary disease. The whole goal around it was to detect an obstructive stenosis, a blockage in a coronary artery, because you had to actually then go in and intervene on that. So that was our whole approach. Guess what? It actually affected such a small percentage of patients. And it resulted in treatment decisions that had to do largely with the treatment of treatment with coronary revascularization, either coronary bypass surgery or percutaneous coronary intervention. And it didn't really optimize and emphasize the use of medical management, which is highly important for preventive care, which I've heard a lot about today. In 2021, this has all changed. But also, I have to tell you that these newer guidelines were led initially by a really provocative guideline from Denmark as one of the first national guidelines to adopt this novel approach to diagnosing coronary disease. So that's kind of cool, right? And it also was followed by UK, and now, the Americans are a little slow. So we were the last in the group. All of you would probably agree with me in this. And this was American Heart Association, American College of Cardiology, and you can see a whole array of other organizations involved in this. So I'm going to focus in on that. So historically, that approach was to induce ischemia, looking for lack of blood flow, which impacts either perfusion into the myocardium or it impacts wall motion. And I'll show you some examples of that. This evolving approach now looks at focusing on the use of non-invasive CT, a CAT scan, to actually look at atherosclerotic plaque. So there is this conflict between the two. And although I could talk about risk stratification in diabetics, looking at myocardial perfusion SPECT, and you can actually see some varying abnormalities, depending on the coronary artery that you can actually visualize, and then you can obviously look at ventricular function. And on the figure on the right, you can actually see a whole array of different risk subsets based upon the percent of the myocardium that's ischemic or has reduced flow, and that including diabetic and non-diabetic populations. But that's not as exciting as what I'd like to talk about. And there are also other methodologies, and looking solely at wall motion. And you could see this grainy image here on the top. I'm being critical, and I shouldn't diss other modalities that are not as high a resolution. And we can actually stratify diabetics. That's great. A lot of this data is 20 years old. And you all mostly are young, and we want to focus on cutting-edge, state-of-the-art imaging. But also, I'm a clinical scientist, and part of those my publications focus not just on developmental work, but on clinical trial work. And this is not my clinical trials, but this is some recent clinical trials, which have shown that if you understand the anatomy of a patient, you understand the burden of atherosclerosis, you can do a much better job of identifying risk in that patient population. And that's what this PROMISE trial data shows. You can actually see in CT, looking at coronary CT angiography. I always put the abbreviations at the bottom for the most part, unless I forgot. So you can give you, in case you don't know the abbreviations, you can see a nice ability to risk stratify, correct? Guys can see normal to markedly abnormal, but not so much here on the stress testing. Can't necessarily differentiate the normal from mildly abnormal, because not every stenosis, not every atherosclerotic lesion actually induces ischemia. You can form collaterals around the blockage and things like that. So it's not as good a tool, stress testing. Patients are problematic. They don't like to exercise, particularly Americans. So they don't do well on stress tests. And so, but sitting under a CAT scan for a few minutes seems to do the trick. And I'm going to get into a little bit more detail. But this has led a lot of guidelines. And here is one from the American Heart Association very recently in type 2 diabetes, which is a position statement that showed and supported that coronary CT angiography has an advantage, particularly in the patient who is at high risk for atherosclerosis, the type 2 diabetic patients and patients overall with stable angina. So we're starting to get more and more guideline support for this, as you can see. But the biggest piece of information that I think should solidify that looking at atherosclerosis should be our primary target has to do with a couple of clinical trials which were published just in the last few years. This is the PROMISE trial again, overall primary trial. This is a $70 million trial sponsored by NIH, NHLBI, Heart, Lung, Blood Institute. So what you see is no difference in randomization of 10,000 patients to a CTA approach versus a functional testing or stress testing approach, but in a pre-specified endpoint, looking at a subgroup with diabetes. And again, another specialty we're not really good at giving you more phenotyping around diabetes that's typical in medicine. You can see that on the top here, you can see here on the, and I'm like challenged with this pointer, as you can see, that you get a hazard ratio of 0.38, okay? So clinical trials 101, 1 minus the hazard ratio gives you the relative risk reduction. So what? A 62% relative risk reduction if you're a diabetic and if you have a coronary CTA as the initial diagnostic strategy to guide clinical management, so CTA-guided strategy. That same benefit was not manifest in the non-diabetics. Interesting. Why is that? More prevalent atherosclerosis, more high risk, and therefore detection of atherosclerosis, and treatment initiated by the presence and severity of atherosclerosis is going to initiate improvement in outcome. This is a secondary analysis. So clinical trials 101 would still tell you it's a secondary analysis, not the primary aim. So it's important, but what you want to look at is now patterns in the literature. And what we also saw from the Scott Heart trial, this is a really interesting and acronym, Scottish Study of the Heart. Really, that's what the best they could come up with for an acronym. So they also showed the same, I mean, look at this, it's amazing. This hazard ratio of 0.36, it's virtually identical to the PROMISE trial. So now we're getting these patterns in the literature, particularly in higher risk patient populations like those with diabetes, that having an understanding the coronary anatomy is fundamental to guiding care, fundamental to intensification of preventive care of cardiovascular disease. And so in the recent ACC-AHA guideline, this is one of the things you get to do when you're old and been around a while. You get to interject a lot of things in clinical practice guidelines that nobody agrees with, and then you force it down their throat, and then all of a sudden it gets published, and everybody goes, oh, that was a great idea that I had. I'm like, excuse me? But that's called research and a career, right? So CTA, so here we have, and I want to just illustrate this because this is fun. This is, all of these patients have plaque. So this is a normal coronary. Do you guys see this little dark spot here? Or this white spot? This is calcified plaque, and this is non-calcified or lipid-rich plaque. It's getting increasingly worse until all of a sudden it results in a stenosis here. So this is our traditional definition, right? It used to be way up here. Look at all the plaque we missed. My gosh, this is 60% of a diagnostic population has plaque. We were missing that. Plaque doesn't go away on its own. It's only going to progress, right? So if we don't identify it, we're not going to treat it. And if we don't treat it, you're going to have the same outcomes you had a while ago. So this is what I get passionate about. I know it's kind of weird, right? But we've now, we've lowered that threshold way back here. So this is normal. Everything else is abnormal. And therefore, all of these patient populations to the right are now all targeted for intensified preventive care therapies, which is really what you're talking about, why you want to do a better job of identifying and understanding diabetes. But if you look at a patient population, it's prevalent. Atherosclerotic plaque is prevalent. You remember those white spots? I don't know how well you can see this, how well this projects. This is just a cross-section, a CT cross-section of the heart. And you can you guys see these little arteries here? They're all white. I'm not trying to identify that. That's a purely calcified lesion. It is so easy to image. You don't have to be imaging expert. You can see calcified plaque because it's like bone, right? So you can see it. This is just so simple. Coronary disease is simple, right? You shouldn't have, it should be, nothing there. But what's nice about looking just at calcified plaque, it doesn't require contrast. It's easy to image. It does require radiation exposure, but a small amount, probably about the same amount as I had from flying over the ocean. And it's generally low cost, $50 to $100 in the US, which is low cost. But look at the prevalence across patient populations, across a whole array of ages. Starts to increase in a woman somewhere around age 45. Everybody knows what happens in that 40 to 50-year-old range. It's called menopause. That actually is once the protective effect of estrogen is diminished, the incidence of cardiovascular disease increases dramatically. And you can see that really nicely illustrated here. And you could see it in men about a decade earlier. So that by the time you get a patient population that is really kind of seeing maybe a cardiologist or seeing a preventive medicine specialist, at least half of them are going to have some form of atherosclerosis. Just think about that. You walk by a clinic and you look in and see people sitting there. At least half of those people have atherosclerosis. Now, I'm not saying if you go by a pediatric clinic, just want to make sure. But, it's really incredible how much we've missed and how much we haven't looked at this in the past few years. Here's one paper from one of my colleagues. It's a very complicated slide, so I'm not going to really go through it. I'll give you the cheat sheet on the right. You can look across the array of patients with type 2 diabetes or no type 2 diabetes across the ages in women and men. Bottom line, if you have calcified plaque at a rate that's 4-fold higher in diabetics, and it occurs at a younger age. So they're going to have atherosclerosis longer than a non-diabetic patient, which is it's mind-blowing. And what is going to happen with that atherosclerosis? It's going to accelerate faster. It's going to lead to much more progressive and worsening disease states, and therefore catching it early becomes fundamental to averting risk, cardiovascular risk in a patient population. I'm just going to throw at you a bunch of slides on looking at this simple measure of calcified plaque. Here's 2 papers from some colleagues of mine looking at this again, this coronary calcified plaque or coronary artery calcium. What we can see in a type 1 diabetic population with, on average, around 20 years of diabetes, this population risk based upon a score. But what's really fascinating in this patient population, so look at the top line, and you see in a patient population 45 to 50 years old, at about a decade, 1 in 4 of them has cardiovascular disease. 1 in 4. That's truly amazing. In the same in the MESA study, we were a MESA site, but you can look at diabetes, metabolic syndrome in people, and in every case, you'll see this gradation of risk. This is just a pattern you see in all of cardiovascular medicine. There's an acceleration of risk, acceleration of atherosclerosis. If I say that like 10 times, maybe we'll all remember it. So, and to get you through the session after lunch. Now, this is where it gets a little cardiovascular. So if you'll just let me walk you through this. If you have an acute coronary syndrome and you've had a previous angiogram, that's looking at the anatomy, acute coronary syndrome would be a heart attack, myocardial infarction, unstable angina, hospitalization, about 2/3 of the time, or 60+% of the time. It would have occurred in a previously non-obstructive stenosis. Was not a significant stenosis. This is fundamental because largely in the past, we ignored that which was non-obstructive. In many cases, the cardiologist would say, oh, you're fine, you can go home, even if you had a lot of plaque, even if it was diffuse and non-obstructive. They would say, no, you're good, you're good. But what I really want to get you to appreciate, because this is how it's going to help in the field of diabetes particularly, is if you look at this cartoon here on the right, one from one of my colleagues, Amir Ahmadi, this necrotic core is a lipid-rich plaque. It is the highest risk plaque. It's that which causes an acute coronary syndrome. If you look at this, there are two ways the plaque can go from there, and this is a 40% stenosis. This is cardiology 101. 40% of the diameter is blocked, and it's a 40% stenosis. That gives you an idea. So stabilization, we can stabilize the artery. We can shrink the lipid-rich component. 5 years ago, if I sat up here and said, I would have got some booze. We now know we can shrink that plaque very easily. We can stabilize that plaque. We can transition that plaque to be more calcified so it's more stable, and I'll show you some examples of that. And here's what happens if it progresses. We can see that necrotic core gets bigger, but it also, the artery starts to remodel, and not necessarily into the lumen, not necessarily where the blood flow, which is really scary because then it's not going to be detected by symptoms or other. So if it remodels outwardly, it can grow where you can't really actually get a manifested symptoms on it, which is really, it's not a good thing, but all the more reason for us to intervene before that patient has a heart attack and potential myocardial damage or death, which is really the goal of us and the goal of our research. And we know from pathologic, this is from sudden death, that there are two components that we see in atherosclerotic plaque. We see a very strong inflammatory signal within the pathologic data, and we also see a huge, bulky, lipid-rich necrotic core and all kinds of lipid-rich plaque, much more than you see in non-diabetic populations, which is fascinating, right? So both of those things we can actually image, and we can actually, including inflammation, and we can actually shrink or alter that sequelae. Not for these folks, right? Because they're already, we have actually a large sudden death group as well that we're just starting to explore. We're a little behind. That's research. So remember, two inflammatory components that are highly prevalent in plaque and diabetics is inflammation as well as non-calcified plaque. We kind of don't like to call it lipid-rich because it's not always that, but in terms of what we like to call it is non-calcified plaque. So. And on CT, here's one of my fellows' papers. We can actually look at the density. You saw the calcified plaque, that big white thing there, and then I pointed to you when it was darker, that was non-calcified plaque. So they are a range across a range of CT radio densities or Hounsfield units, where we can actually measure across the range from a Hounsfield unit of -30 to 30, as well as all the way up to, on the right, more than 1,000. And you can see on the bottom of the slide some interesting correlations between Hounsfield units and, but the bottom line is if you look at the blue line, everything to right of that, to the left of that center line is non-calcified plaque. That's low-density plaque or necrotic core, fibrofatty, and fibrous plaque. And there's been all kinds of pathologic and invasive imaging correlations. And everything to the right is calcified plaque. And the more dense the calcified plaque gets, it gets more and more white on a CT scan. So, being a very visual person, I like the fact that everything's color-coded. I'm kind of a simple, so this is where it gets kind of fun for me. But what's interesting is there's plaque, actually, that can be so calcified that it has the same density on a CT scan as bone. We can hit it that hard within our coronary arteries. It's fascinating, right? Well, it is to me. You guys can just amuse me, right? So, but it's kind of fun. And so we can actually then, this is some of my research, but it's one, I try to highlight the fellows' work. And this is one of my fellows from the Netherlands who was with me for a couple of years. And Alex did this subsequent paper from the iconic registry. What we looked at in this registry was to look at precursors of an acute coronary syndrome or acute myocardial infarction. And he looked at what was, again, across the same array of subgroups with plaque. And all of you can see, if you look at the necrotic core, that red stuff, that's not good stuff. And it gets more greenish, and then it gets darker green when it's fibrous, and then it gets more and more. So it's what we call 1K plaque or 1,000 Hounsfield unit plaque, which is blue. And what is fascinating, if you look across an array of these different groups, you can see that as you get really dense calcified plaque, you're less likely to have an acute coronary syndrome as when you have a lot of necrotic core. So by these subgroups, we can actually identify precursor features in a patient that would lend themselves to being at risk for an acute coronary syndrome. We can also get an idea that if it calcifies, if it gets old enough, because that's what that's a marker of, it's been around a while, that it's calcifying and becoming more stable, then we know that patient's risk is less than it would be, much less than it would be in the patient who has necrotic core or fibrofatty plaque. There are other high-risk plaque features, which is interesting as well. I talked about some of these in that little cartoon from my friend Amir Ahmadi. So you see here, again, the artery can do one of two ways of remodel. It remodels negatively or into the lumen, blocking blood flow, or it can remodel outwardly. And it usually remodels outwardly first and then goes inward. It gets to a certain amount and then it goes inward. So that's a high-risk plaque feature. And low-density plaque, we talked about this. There's another one called napkin ring sign. We don't see it that much. Some people see it a lot. I don't know, maybe we're just a little slow in New York. We don't see it very much. But it is this kind of central area of low density that abuts the lumen, and that's the critical part. If you're going to look at plaque rupture, it's got to rupture so that it goes into the lumen and therefore attracts a clot, and then all kinds of nasty things happen after that. But what's fascinating from this is that any of these high-risk features will elevate risk. If it's just present, any high-risk plaque feature, if it's present, you can see an increased risk in as little as 2 to 3 years. Now, in what I do for a living, that's a very short period of time. We actually then also published, using the Scott Hart data, we looked at this low-density plaque here on the bottom, and we looked at the combination of patients. And so if a patient had non-obstructive disease, again, we used to dismiss that. Now we understand the importance of this. Combined with the high-risk plaque features, their risk of myocardial infarction was elevated almost 7-fold over a very short period of time. That's a very, very high risk. So this one I'm like so fascinated by. This is looking at pericoronary fat. We actually see that there is fat around the coronary arteries, as there is fat around almost every arterial bed, and what you see is that you can actually image this using radiomics, which is a form of kind of machine learning, artificial intelligence, where we're looking at a textural analysis on the top upper left. This is from a group in Oxford that we work with, and here you can see a culprit lesion. Look at can you guys see all that red? Very high risk, very, again, Hounsfield units. All that red is high risk, very inflamed fat around the coronary artery, but look, not so much over here. So there's all kinds of patterns we can see with this, which is kind of cool. I'll also tell you that fat in other arteries can be problematic. Fat around the uterine artery during pregnancy leads to preeclampsia. So fat around arteries is just, it's not a good thing. It leads to vascular dysfunction. In this case, that we believe that the fat actually can, in an inflamed state, will actually diffuse the lipid-rich plaque, the fat, into the coronary atherosclerosis and make it bigger until it actually results in an acute event. So we can image this again with CT using this pericoronary perivascular fat attenuation index that was, and this radiomic signal has been developed by these guys at Oxford, and it's highly predictive of coronary disease mortality and myocardial infarction. We have a large COVID grant from NHLBI where we're looking at pericoronary fat, and so that we can actually see if that systemic infection will actually inflame the plaque and cause atherogenesis and marked progression of atherosclerosis. So fascinating work, not just in the coronaries, but around the coronaries as well. Now, why do we want to do this? We have two goals now. We've shifted away from our dated goal. Our two goals are, can we look at progressive worsening? Can you guys all see? This is a CT scan. It's just a different software package. Not much here, but look what happens. This is in a year. This is in a patient with a high elevated lipoprotein A, which is, highly atherogenic. Man, these people progress. This is incredible progression. You can see here. So this is not a good thing. We don't want patients to progress. So we want to stabilize the plaque, but we can, with treatment, we can take plaque that looks like this. This is a patient, a real patient, that has a ton of plaque, including that low density or necrotic core, and we can shrink it to this after 18 months of therapy on a highly enriched fish oil, Vasipa or icosapent ethyl. So this is where it gets exciting, right? We can actually then now start to talk about regressing coronary disease. There's actually not much data, so you're going to be, this is so anticlimactic, right? I had you built up into all of the thrills of looking at atherosclerosis, but now I can tell you that we're really on the cusp of now we know we can do it, we can reliably do it, and there's really only a couple of examples in the literature that I can bring out to you. One, again, is Matt Budoff's Evaporate trial, which was just published a few years ago, using this Vasipa. You can see this example. And Vasipa is used for patients with elevated triglycerides, already taking a statin. So again, we're eliciting benefits on top of statin therapy, which is given for dyslipidemia. So the primary endpoint, as you can see, but look at all these reductions. Again, just up until a few years ago, nobody thought we could regress this plaque. Everybody thought once you had that footprint would never change, which is interesting because we know that we can actually elicit that change. But what's super important is we don't just show you pretty little pictures of how the plaque shrinks and all of that. And we actually develop a prevention strategy that actually would improve outcomes, right? We want the patient, whoever they are, especially the patients with diabetes, not to have a fatal or non-fatal cardiovascular event, particularly a fatal cardiovascular event. And so there is some examples in the Scott Hart trial where they recommended for all patients with atherosclerosis that they use a statin therapy as well as aspirin, which is like minimal cardiovascular prevention. In this patient population, they tracked the use of statins throughout the trial and were able to elicit, not in the primary trial, but this was in a pre-specified follow-up. There's all these rules to clinical trials, so if basic scientists, you're really lucky you don't have to do all this rules. It's important, though. We want to establish really important what the evidence means. We saw from Scott Hart, and after a 5-year, when we moved from 3 years to 5 years, we actually then saw this benefit. So again, perhaps when we're just learning, we're learning that we need a little bit longer period of time in order to elicit a therapeutic risk reduction. So fascinating data on the role of shifting away from older modalities to more conventional imaging with CT so we can image Not only we can image the atherosclerotic plaque, we can actually look at subtypes. We can actually get a better idea of ones that we can regress, and therefore then we can actually start to think more aggressively about clinical trials. So I said you probably might get all dismal because there's not many trials. There's a ton of trials ongoing, because if any of the clinicians in the room know, we have, I don't know, probably 10 whatever different trials, different substances being developed for different targets, particularly around lowering cholesterol. There's this focus in cardiovascular medicine about residual risk. We've been able to do relative risk reduction, about a 30% relative risk reduction, but we have a huge problem with cardiovascular disease and residual risk beyond that with conventional therapies like statins. And so there's a lot of new drugs, and they're also extremely expensive. In a lot of injectables, try to increase adherence and compliance with patients. Twice a month, give yourself a shot, or you go to your doctor to have them give you a shot. So all kinds of ways where we can spend $250,000 a year in therapies, but that's another story. So this is why the newer guidelines are going to focus in on anybody who has atherosclerosis. Intensifying preventive strategies and not necessarily embarking on any other types of diagnostic approaches. Of course, we're not belittling what we should do with the patient who has significant obstructive disease. Those patients really are in that category that really need intensification of guideline-directed medical therapy. Importantly now, there's this movement, and I think this is where it becomes important for all of us to understand, is that these patient populations now should, particularly the non-obstructive, should not have primary prevention targets. They should have secondary prevention targets. That's a little bit much for the American cardiologist to swallow. So you all are a little bit more forward-thinking, so maybe you can embrace that and now say anybody with atherosclerosis should be in the category of getting secondary prevention. So very interesting work that's ongoing, at least it is for me, on diagnosing coronary disease, and it highlights the role of the burden of atherosclerosis, high risk at a younger age, more atherosclerosis, more progression, much higher risk associated with that. We've got a fair amount of data. I don't think we have data as well as all of you would like. Of course, that's why they call it a career. I never have data as much as I would like, but it's important for us to see that if we can target the right abnormalities, if we can target the right disease markers, we can intensify care. And we're not waiting for a preventive therapy necessarily down the road. We do have both statins and angiotensin receptor blockers that actually can regress atherosclerosis and have proven clinical trials to do that mostly in the invasive literature. But I think it's a really cool time to be looking at atherosclerosis, in large part because we can shrink the plaque. There are all kinds of methodologic considerations that we have to break through, but I think it's just really an awesome time for us. This is an example of why we want to really target. This patient has a lot of plaque. You guys can see this is the lumen, that line, and then you see the vessel wall. Everything in between is plaque, and this patient then 2 days later had a myocardial infarction. So this risk can be very risky. This plaque can be very risky and can result in, the more plaque it is, the more non-calcified it is, the more low density plaque. It's a near-term risk and not just necessarily a long-term risk. And I want to thank you from New York City and let you see my group. So thank you so much.
Thank you very much for this very nice talk, and now we have time for questions.
Jordi Merino, University of Copenhagen. Thank you so much for a very impressive presentation on a very important topic related to obesity, diabetes, cardiovascular risk prevention. So my question to you is what's the value of ultrasound assessment of carotid plaque and carotid intima media thickness? Because as far as I know, all the data that you're presenting, it's based on CT scans. Those are somehow invasive. People tend to use ultrasounds to measure to determine whether there are plaques or not, and the amount of lipid that it's infiltrated under the subendothelial wall. And then the second question is whether we should also look at this intermediate phenotype, which is increased carotid intermediate thickness without the presence of plaque. Because plaque, it's not yes or no, it's like atherosclerosis, it's a progress that starts with endothelial dysfunction and then progresses. So I wanted to know your opinion on that.
That's a good question. You know, ultrasound imaging, the carotid is a bigger artery, so it's easier to image, right? The challenge is the reproducibility of the carotid imaging is not where we want it for clinical application. So there are some centers that use carotid imaging, and there's correlation, right? If you can predict one, you can predict atherosclerosis in one arterial bed, you'll likely, have some overlap in other arterial beds. But it's not as reproducible as we would like, and particularly looking at intima media thickness. It's highly variable, and it depends. If you're good at it, you're good at it. If we probably would get too much variability, and so it's generally not recommended, even though you think it could be. And it has to do with developing the evidence and really improving it. I don't know if anybody is working again on that, with more AI-based, there's a lot of ongoing activity in what I'm doing. Some of what I showed you was AI-based to look at automated segmentation, and usually that can improve reproducibility, right? Let the computer make the mistake, and that makes it less than me. But not as much as we would like, and therefore, and there are clinical trials, particularly in the carotid intimate media thickness space, but not as much as overwhelming and consistent the way we see. As a researcher, you can't do all the evidence. I just look for patterns and consistency in the evidence, and then I latch onto it. But when there's inconsistency, it's much harder, and it has to do with reproducibility.
Yeah, what is the name of the Danish guy you mentioned in?
The guideline?
Yeah, no, you said
the Danish person that you mentioned.
The Danish guidelines that were published apparently was a governmental guideline or that was published about CT angiography. I think this in Denmark, you have a lot of ongoing CT research. There's a big, large registry of CT across Western Denmark. Bjarne Nørgaard has led a lot of that, a cardiologist here, and they've done really some seminal work in this area.
The other question is about alcohol. In old times, we learned that alcohol prevents atherosclerosis. It's bad for the liver and a lot of other things, but red wine, the people that drink a lot of red wine are saying that it prevents these things. How is it today? What is your opinion?
It's consistent with the Mediterranean diet literature, right? And particularly red wine. There is a threshold, though. Canadian guidelines just recently came up. I mean, there's a cancer risk. Everything you do in your life is a balance. Everybody was in a tizzy last weekend was the American College of Cardiology. And right before that, the Canadian guidelines came out and say more than 2 glasses of wine a week increases your cancer risk. And we all went, 2? Oh my God, what am I going to do? But it's there is, but it's a focus really on Mediterranean diet that really gives you that. I mean,
but does it prevent atherosclerosis?
Atherosclerosis, correct. A Mediterranean diet is the one that consistently comes across. You guys can think of it: fish, grains, less processed foods, etc. And that is when you look at alcohol, you can't. It's very hard for you to separate alcohol from diet, as well as other adverse behaviors like smoking, etc. So
you do not recommend it to your patients?
No. I think if you enjoy it, then moderation is key in most things in life, right?
Hi, over here.
Yeah, thanks.
My name is Erik Richter. I'm from the University of Copenhagen. So you didn't mention much about exercise. And I was wondering the regression of the plaques that you see with statins and fish oil. Is there any evidence that increased physical activity also leads to regression of already established plaques?
Well, first of all, I live in the United States, and not many people exercise. So
There are still some, I
no, I
guess.
know. No. I live in New York. We have to walk everywhere. I don't own a car. So, no, it's a valid point. And I thought about mentioning it, but I was hoping somebody would ask me. So there's not a lot of data for it in contemporary patient populations. I think like anything, like the statins are going to give you a more potent kick in terms of reducing cholesterol, or Vascepa, or any of the PSC, the injectables, sorry. They will give you a more potent kick. I would guess that if you had exercise, that you would have to have a sufficient intensity, as well as, number of frequency per week, and probably over a longer period of time. So those of you in the room don't know me or a lot about cardiovascular disease, but I used to play field hockey with Dr. Julie Zirath 40 years ago. So that's why I get the invite to go visit my friend, which is awesome. She could run faster than me, though. True? True. All right. You have to acknowledge when you're beaten. No, I'm making a joke. But no, you're absolutely right. It would be great if we could look at not only exercise, but other types of modifying behaviors that we can elicit, largely because that would have to be NHLBI or NIH sponsored. Not many pharmaceuticals would sponsor it. And the average American, where you take them, probably isn't capable of doing sufficient exercise in order to elicit that regression. I'm going to be out there. But certainly there is hope that other types of dietary modifications and reductions in other types of behaviors would be important.
Any other questions? We have time for maybe one brief question.
Hi, Svenja Hansen, also from University of Copenhagen. As I understand it, statins also increases the risk for type 2 diabetes. Could you comment on this relationship?
Yeah, I mean, I think you just said it. I mean, that's a real concern, and that's why there's monitoring if you're on statins. But they are very potent in terms of a cardiovascular effect. This is the challenge, right? Everything, particularly in an adult population, everything's a balance. Everything, you have to weigh those balances in terms of therapy. We don't get patients to really do sufficient diet modification to lower their cholesterol to where it should be. The targets right now, I don't know, how many people know their LDL cholesterol? You guys, none of you know oh my God. The targets now are like under 70. Could you do that on diet? I mean, that's incredible. I mean, you have to be very strict with your diet. So if we have to use pharmacologic intervention and then watch for those side effects in the diabetes, that's how it's managed. The hope is with some of these newer drugs that are under development, targeting lipoprotein A and other types of, inclisiran and other types of drugs that are on the market or entering the marketplace, that we won't see that effect. But it's an important consideration. Thanks for bringing that up.
Thank you. I think in the interest of time, we would like to thank Leslee.
Oh, thank you so much. That's awesome.